Everyone, and welcome to our last panel before lunch. It is a very exciting panel about the pandemics of today and tomorrow, and we're very lucky and excited to have a lot of lovely people with us today, including Professor Dame Ann Johnson, who is the Professor of Infectious Disease of Epidemiology and the President of the Academy of Medical Sciences at the University College London. We have Deepali Patel, who is the Director of International Policy at AMR Action Fund. Dr. Ekaterina Malievskaia, who is the Chief Innovation Officer and co-founder of Compass Pathways. And Matthew Scholz, who is the Chief Executive Officer and co-founder of Oisin Bio. And then we also have chairing with us today Dr. Chris Booth, who is the CEO and co-founder of FYR Diagnostics. And without further ado, welcome to our next panel.
Hello, everyone. Thank you for having us all here. I swear I'm not on TikTok watching videos. I just prefer electronic notes. But thank you for having us all here. It's a real honor for me to be here. I was a GAP Summit attendee back in 2017, so it's really cool to come full circle and be able to participate in a different way. So I very much so appreciate the organizers for inviting me to this. I'm going to give a little bit more background about ourselves just briefly before we get going, just to kind of give you some more context about what we all do, why we're here. So I have a diagnostics company, and we do focus on non-invasive liquid biopsies for various diseases. But during the pandemic, we built a clinical lab for doing COVID testing in the state of Montana in the United States. We built the first high-throughput automated clinical diagnostic lab in the state to be able to help provide those resources. Anne has quite the career. She is just a knowledge wisdom bomb over here. Her career was focused on research into epidemiology and prevention of HIV and sexually transmitted infections, as well as other infections such as influenza, Ebola, AMR, COVID-19. She co-directed the Medical Research Council, the UK Centre for Coordinating Epidemiological Studies of HIV from 1985 to 1999, undertaking a range of epidemiological studies and trials. So, just fantastic. Deepali is, as mentioned, the Director of International Policy at the AMR Action Fund. The AMR Action Fund was developed in collaboration with the WHO, the European Investment Bank, and the Wellcome Trust. It aims to overcome key technical and funding barriers of late-stage antibiotic development and will work with governments to ensure there is a sustainable pipeline of new antibiotics to fight superbugs. The Action Fund aims to invest more than $1 billion to bridge the funding gap and respond to the AMR threat, and is hoping to bring 2 to 4 new antibiotics to the market this decade. Ekaterina, the Chief Innovation Officer and co-founder of Compass Pathways. It's a mental health care company dedicated to accelerating patient access to evidence-based innovation in mental health. The team at Compass is committed to discovering and developing new therapies that will help patients and their families and ease the burden on our overstretched healthcare system. And they have their first program that they are researching is how I think COMP360, psilocybin therapy, could help people with treatment-resistant depression, which is fascinating. And Matt from Oisin Biotechnologies, his company has been demonstrating that the solution to mitigating the effect of age-related diseases is to address the damage created by the aging process itself. And they are doing this by developing highly precise DNA targeting intervention to clear senescent cells. He is also the founder and CEO of Immusoft, a biotech firm developing a breakthrough technology that will turn a patient's B cells into miniature drug factories. And they recently just received an open IND for their first B cell therapy. So congrats. That's very cool. It's a big deal. It took like a decade, right? So yeah. All right, so enough about us. The panel is pandemics of today and tomorrow, and I think by default it's very easy for us to all think COVID-19. I mean, rightfully so. I mean, admittedly, when I first saw the panel, that's where my brain went as well. But as you can see, the backgrounds of the panelists are not just infectious diseases. We have aging, we have AMR, we have mental health disorders. So I want to set the baseline here that while we're talking about pandemics, we're not just talking about communicable diseases, infectious diseases. There is a much broader topic here, regardless of whether or not these, like mental health, might not be in the public perception considered a pandemic, or our governments don't respond necessarily to these types of threats in the same way. So hopefully the goal here is to identify that, discuss that a little bit more, and why are some diseases considered something like a pandemic, and why are others kind of neglected? So the two main topics that we're going to be going over, the pandemics are inevitable, so how do we prepare for them and manage them proactively in that context? And what are the big hurdles in healthcare that we expect in the future, and tying it to public health and everything. So to kick things off, I would be interested in hearing from the panelists, kind of from their perspective, what constitutes a pandemic and why are some disease focused on and some are not? And I know that's a very broad question, but I feel like it's an okay place to start. I was thinking, Anne, maybe based off your career and everything, it would be interesting to hear your perspective about traditionally, how have we identified what is a pandemic? And from all of your experience with that, what do you think needs to be different?
Okay. So, well, the word pandemic, or the word demos, is, of course, for those who, I think it's Greek, is epidemiology, comes from epidemics, upon the people. So this is all about things that happen in large numbers of people. Now, with respect to infectious diseases, we usually talk about pandemics when we see an infection, which may not be a new infection, but if you think about a flu pandemic, you get an emergence of a new variant, which we don't have immunity to, and you begin to see the spread of an infection that goes right across the different continents of the world, and that's what we think of as an epidemic. And classically, the ones that I've worked on through my lifetime are three, I think. The first one was the HIV pandemic. The second one was a rather weedy 2009 flu pandemic. And then, of course, this one, which has not been in that category. But I think we can also think about pandemics as being global problems that are not necessarily infectious. And actually, of course, if you think about what we've got presented here, we're actually thinking about interrelated pandemics. So we are as globally living longer. Now, the problem of aging, I don't think we should see it as a problem. I'm the oldest on the panel. Thank you very much. We need to think about healthy aging, and so I don't think that's a disease, but we certainly know that having an older population means that we have got new problems to deal with, multimorbidities, people having multiple things wrong with them, and what we really want to do is to have a long, healthy lives and a relatively short period of disability at the end of life. I guess that's the ideal. But remember, they interact. Who is it that has really had the highest mortality rate? It's the older populations during the pandemic. What has the pandemic done for mental health? I think it's highlighted the extent of untreated, unmanaged mental health, and probably we'll have to see in time has resulted in higher rates of mental health problems. AMR is driven by exactly the same kind of global environmental impacts, which I think we can think about when we trace back the origins of the COVID-19 pandemic, how rapidly it spread around the world. We have to think in those contexts about environments, about globalization, about how we live very closely together as a society. But then I think the last bit is the agency. I started with demos, the people, and it's actually the people, all of us, is public health is about the collective efforts of society to counter ill health. And that goes far beyond what we do in hospitals and healthcare centres. It's about how all of us as a society contribute to the control of an epidemic. And, you know, we think of vaccines and high-tech things that have solved the pandemic. They haven't, A, solved it, and B, a lot of the reduction in damage has come from our individual and collective efforts to protect one another and prevent transmission of the virus around the world, remembering that for many countries access to vaccines has been limited and we're still seeing a lot of transmission. So these technological solutions, which everybody in this room is involved in, are immensely important. but they're in a sense only as good as the systems that we are able to place them in, and global health equity and how we think about those things around the world to solve pandemics. That was rather a long answer, I beg your pardon.
No, it was perfect. Thank you. Thank you. To lead off of that a little bit, I'd like to bring up the mental health component of the pandemic. So it's estimated that 1 in 8 people have a diagnosable mental health disorder. Please correct me if I'm wrong on any of these numbers. I just copied the WHO. Yeah. So, and it was estimated that during the first year of COVID that there was a 25% increase in mental health disorders globally. It's massive. And if you look at those numbers, it's generally equivalent to the total amount of COVID cases that occurred in that year as well. On average, since the COVID pandemic started, that's about what it is. But we don't think of it that way.
We don't.
And why don't we think of it that way? What are the challenges that we have to overcome to consider the mental health in the same regard as something like COVID? Because it's been here, it's just getting worse.
Yeah. So I think the mental health challenges definitely meet the criteria for a pandemic. The challenges are global, and they are, with some cultural variations, are, pretty similar across, geographies and languages. You're absolutely right. 1 in 8 people live with diagnosable mental illness. In the U.S., 1 in 6, and in the U.S., 1 in 20 people live with serious mental illness, which means that their daily functioning is significantly impaired, and impaired not for days or months, impaired for decades. If we talk about infectious disease, they get better or get worse or get treated, but they don't kind of stay the same, through decades. With mental illness, if it's undiagnosed, untreated, treatments are ineffective, then there are, additional side effects from treatments. It can go on for entire patients' lives. And not only for patients themselves, the entire ecosystem around patients is affected, family, friends, and just think about 1 in 20 people do not function properly. So we're missing on a contribution. 1 in 20 people, their talents, their aspirations, their hopes, they're not present for their children. So I think it's a ripple effect. The other point I wanted to make is that mental illness is radically different from any medical disease. So I was trained in internal medicine, and I practiced internal medicine in the U.S. And the practice is very different. You walk into the room with a very sick patient, and you have a plan. You can access, tests, scans. You can call consultants. You can formulate the plan. There are no hard endpoints in mental illness. The diagnosis, the clinical impression, is kind of emerges, from the interaction of what patient is willing to share and what kind of day a psychiatrist is having, or clinician is having. And then somewhere in this space in between emerges the clinical impression that one day could look like bipolar, another day like depression, another day it could be. It's a bit of a whack-a-mole. So when we talk about these numbers, I think I don't have a huge faith in numbers. I think it's hugely underestimated. I wanted to maybe double click on Anne's point about the agency and what as a society we can do for mental health epidemic. I think we started talking about this, and I think people started coming out with their stories and trading, sort of war stories about their struggles with mental health. That's not enough. I think part of the stigma is that because we simply don't have effective solutions, effective treatments, the treatments are complex, and the mental health patients, they, as opposed to, HIV patients, AIDS epidemic in the U.S., in San Francisco, when there was a movement for access, mental health patients don't tend to organize. They don't march on Washington to demand more funding. They don't. They're by nature, the mental illness is the disease. All of these disorders are disorders of separation. So as a society, I think we need to recognize this and stand up for these patients and support them and their families in, in designing acceptable solutions.
Thank you.
Yeah.
A lot of challenges there, that's for sure. I'm going to shift around. Another concern, I guess, about or challenge with trying to think about pandemics and what they are and how to fight them is, I think, something like AMR. It's not a question about if it's going to happen, it's a question about when and how are we going to deal with it when it happens. And particularly in a field where there isn't profit in necessarily making something now for something that's going to occur in the future, but when it happens in the future, it's going to be too late if we don't have solutions already in place. So I'd like to ask you, what do you think the challenges are in trying to promote the development of drugs with that whole context, and what are the challenges with trying to address AMR when right now most people, don't necessarily see it as an immediate issue. I mean, we're struggling with stuff that clearly is an issue that we still struggle with addressing. So how are we supposed to address something like AMR?
Yeah, I mean, I think, and maybe also tying this to your first question about kind of how do we characterize pandemics, I think maybe before COVID, people didn't think about pandemics. Kind of people outside of public health didn't think about pandemics. And now somehow we think about pandemics, as things that kind of exist outside of time and space. It's like we've frozen our regular lives and we deal with this pandemic, and then the pandemic will end and then we go back to our lives again. But that's not how it works. And we've had pandemics in the past, and either these viruses become endemic or they continue to be public health emergencies like polio, for example. And so I think we really need to think of a different way of thinking about what a pandemic is and what its impact is on us. And so I hear AMR, and maybe I'll just take one step back in case people don't know what AMR is, because I think this is part of the problem. AMR, antimicrobial resistance, or I think drug resistance is probably the easier way to think about it. It is essentially pathogens that evolve to become resistant to the common treatments that we have for infectious agents. And it's interesting because I think it's becoming a problem. It's becoming maybe a bigger issue in the public awareness now. And in 2016, there was a big report that came out of the O'Neill report, the O'Neill Commission here in the UK, that I think really shone a light on it. This year, we had a report in the Lancet that kind of showed what is the actual burden of AMR? Over 1 million people a year die directly from drug resistance, and 5 million people a year die from associated drug resistance. And 1 in 5 are kids, and so it's really a bigger problem, I think, than people realize. But I think what people really don't realize is that it's not a new problem. The minute you start testing a drug, you start developing resistance. Penicillin had resistance way back when penicillin first, came out and was being used. And we just didn't really have the tools to know that or really to understand that. And so this is I think we think about pandemics as like a tsunami. It's like we're on the beach, we're having fun, and suddenly the big wave comes at us and swamps everything. AMR is like a flood. It's like the water is already around our ankles. It's already around our feet. It's slowly rising, and we're not going to really realize it's a problem and do something about it till it's like somewhere around here. And somewhere around here is not going to work because it takes like 10 years and $1.5 billion to make a new drug. So, it's going to be up here before we can get anything out. So I think that is really a big challenge in sort of understanding this is a problem that we already experience, and I can throw interesting statistics out there, but something I learned recently is most people who have cancer, when they die, they're not dying from cancer, they're dying from an infection. And that is the sort of secondary kind of morbidity that's associated with chronic conditions that is related to AMR. And so maybe it's an infection or a drug-resistant infection, but I think it's things we don't think about. And if you think about you need to go in for a surgery, you need to have maybe as you're aging you get a knee replacement or a hip replacement. you have a chronic condition all your life, you have diabetes, you have, you will at some point get an infection and need that to be treated. And it is going to be increasingly harder to treat those infections. And we are going to lose confidence in our ability in the health system to be able to address those needs. At some point, you're not going to want to go in for a knee replacement or a hip replacement or any kind of surgery like that, because you don't know if you get an infection, if that's going to be treated, and you might lose your leg. And so I think it's these types of things. I mean, it sounds really scary, but that's what we're going to face in the next 10 years, 20 years, et cetera. And I think these are really the challenges. And then on the sort of policy side, or the antimicrobial development side, WHO put out a report this year that says, the pipeline is collapsing. It isn't just that our existing treatments are kind of rapidly losing effectiveness. There's not much in development right now. Because and most of it, like 80%, is being developed by these really small biotech companies that maybe they have 3 employees or 5 employees, and they're really working on the edge. Like, one thing will send them over into collapse. And, they maybe will get a product to the market and be successful, and that'll be great, and then they will go bankrupt. Because, as you're kind of getting over that final hurdle into licensure and marketing, it gets very expensive. And there's nothing on the other side, because actually what we want with the new antibacterials, antimicrobials, is not to use them. We want to keep them in reserve so that when you really need it, you can use it. So you don't get big volumes, and so kind of in our current economic model, pharmaceutical companies are not going to turn a profit. Even before profit, they're not even going to recoup their R&D investment costs. Like I said, it's like $1.5 billion. You're not going to make $1.5 billion on an antimicrobial before the resistance has built up and it's no longer effective. And so this is I would say it's a public health challenge, it's a market challenge, it's an awareness challenge, it's a policy challenge, it's a funding challenge. And so, I mean, that's one of the things we do is we're trying to prop up the pipeline right now by investing and infusing $1 billion into it. What's that going to get us? It's not going to get us a whole new toolbox of antimicrobials. And so we also need governments to step in and say, we're willing to pay for what we value, pay for what we care about, and that is having this kind of really robust toolbox so that we can address this problem. And again, we have a lot of other challenges. I think we underfund mental health, we underfund all kinds of infectious diseases that have been with us forever. We underfund so many things, and it's like, if I put $1 here, I don't put it there. I put a pound here. I don't put it there. Where do you put the investment? And I think that's really, I think ultimately, to me, in the end, the pandemic is like a massive underinvestment in health. Like, I don't even know if it's a disease issue. It's just, what do we value? What are we willing to pay for? And I'm not sure that these things match up.
Mm-hmm. It's very interesting. I want to come back to some points about that, but I want to give Matt an opportunity to talk about aging in the context of disease, and do you agree that aging isn't a disease, or is it? It's a very complex subject matter, and within that, how does the industry feel about trying to identify and prioritize what we should be addressing with aging? The older population is getting larger and larger every year, very quickly. There's a lot of age-associated diseases that are then, increasing with it. Healthcare costs going up. So how do we define, identify, and target all of this?
Yeah, I mean, patients are getting older and diseases are getting more chronic. I guess it doesn't bode well. And this discussion about whether aging should be considered a disease, or even what aging is something that's very much being wrangled with by the community itself. And I think I'm generally of the mind that calling aging a disease is kind of a misuse of the nomenclature to a certain extent. But one of the desires to call it that has to do with the way that we approve drugs, and that you can't have an approved drug if there's not a disease. And so you have to figure out how do you construct endpoints that would be recognizable by the regulatory authorities in the world and then reimbursable. And I think fundamentally, you think of aging as the master corollary for pretty much any immunity or any kind of malady you could think of. And kind of a funny example, but you have way worse odds of having cancer as a clean living 70-year-old than you do a chain smoking 20-year-old. And I mean, that's not to say that your ill-spent youth isn't going to haunt you later, or the epidemiologist won't string me up. But age itself is this massive risk factor, and it dwarfs everything else. So when you start looking at these stats that are going to say, okay, 20% of your population is going to be over 65 in a few years, you're looking at some massive increases in chronic disease. And so there's a very powerful incentive to want to try to address aging more mechanistically. And this, I think, is, yeah, in all fairness to the skeptics, this has been ground zero for snake oil for thousands of years. Like, people have been trying to build anti-aging potions forever. But we really have gotten to the point where, from a science perspective, we can understand a whole lot more about the underlying causes of these things. And I mean, you think about the history of medicine has been mostly, plants and prayers for millennia. That, like, small molecule drugs and rituals. And I would say, I know, admittedly a little controversially, but that we're never going to cure aging with pills. You're not going to be able to, like, undo this mess. An analogy I like to use is that's a bit like trying to debug Microsoft Word by changing the microchips in your computer. It's why, like, every drug you buy has a list of side effects way longer than the actual intended effects. It's monkeying around with this chemical substrates in life. And so, all I'd say, like, we've gotten to the point where there are companies like mine and many others now that are trying to address this at a more mechanistic level. And the goal isn't just to kind of, say, add years to your life, it's to add, life to your years. Like, the goal here is to compress morbidity. And so you live in perfect health and die rapidly. And I think that's something that everyone can get behind. From the patients don't want to be sick forever. The payers don't want to pay for them to be sick forever. And but to accomplish this, you need to kind of rethink the way we approve and develop drugs. And I'll stop there because I can go off on a longer tangent.
Oh, are you sure? Okay, all right.
I construct my soapbox.
Fair enough. Thank you. Wow, time is flying. So in an effort to try to address the second item, which is more focused on the future of healthcare and what are the challenges, there's a question I'd like to ask everybody, and so you'll all get a turn at this, but what are the biggest challenges that we face with dealing with healthcare in the future? Is there something that's identifiable to you that is like a single most important factor? And where do you think healthcare is going to be 5 to 10 years from now? Where do you think it's going to be 20 years from now? Very hard question to answer, but the basis for this is technology has just accelerated at an unprecedented rate. What we're capable of doing now with molecular sciences is incredible. But we haven't solved everything, clearly. We're dealing with so many out of control disease areas and haven't addressed it all. So why? And is that something that we can do in the next 5 to 10 years or 20 years? What needs to be overcome in order for us to truly unlock the potential of the technologies that we're developing and address all of these global issues? So if anyone wants to go first.
Can I pitch?
Yes, absolutely.
So I'm going to put first on the agenda something we haven't raised is inequalities. So you talked about ageing. In fact, we know that life expectancy in this country and around the world is immensely variable according to your socioeconomic class, and you can move from, there's a statistic as you go along the central line out of London that where people living in each borough of London, each mile down can't do it in kilometres, mile down the tube line, your life expectancy drops by, I think it's a year or something like that. So there's a massive difference in our country between life expectancy. Why? And it's not just our access to healthcare. It's to do with the entire environment we live in. Our whole experience of wealth, education, a work environment, legal frameworks, built environment, the whole shebang. So if we think about public health, we do have to move the lens into thinking that managing the health problems that we face is not simply about health care, it's about the broader determinants, but also it's about preventive care. So I'm interested, you made the statement that you can't have a therapy if there isn't a disease, but of course, there's been a big debate, for example, about pre-exposure prophylaxis for HIV. That's giving healthy people, a drug, for example.
Vaccines.
Equally, we use a lot of interventions now for heart disease and so on, which are essentially preventive interventions, but it's a whole bunch of other interventions which are outside the health system. So it seems to me we should stop. In this country, every minister in each government says they're going to spend more money on prevention because they'll reap the benefits of that, but they never do. So we're always, in the business of picking up the pieces rather than preventing them happening in the first place. Same with pandemics. Best pandemics, a dead pandemic, never happened because we managed to detect it early, intervene early, and stop it happening. So I think addressing inequalities is a huge issue. Addressing end-of-life care, which you talked about, is another one. Addressing social care is very high on the agenda. And all of these have to be seen through, I think, a broader lens of health. I accept the criticism of that analysis that says, well, there's a bunch of stuff you need to change in the world to do anything about health, which is clearly correct, but equally, we can't boil the ocean. So in the tech space, what are the opportunities for medicine? I mean, I am absolutely fascinated by how slow medicine has been to adopt digital technologies and to adopt remote technologies for health. The pandemic was, if there was any good thing about it, was a big driver of that. We stopped the computer says no problem and moved forward to a lot of digital interventions and remote consultations, which I think have been very important. But we need to use, because of the fear of a digital divide, socioeconomically, because of access to these sort of technologies, we really have to think about how technologies can be used to reduce inequalities. And a simple example is being able to avoid having women having to trek up a couple of hours to a hospital when there's no bus service from a rural part of England with their antenatal care, when it could be delivered by remote access and by taking the service there, those kind of things. So we really have a huge opportunity to transform health care and social care through digital delivery, but it needs to be done in such a way that it enables access and enables reduction in health inequalities, which are a big driver of what we see in terms of illness and
Yeah, I mean, if you think of the last 100 years, we've more or less doubled the average human lifespan.
Yeah.
Notably, we haven't increased the maximal in recorded history. But we did this mostly by changing the environment, like starvation, predation, hygiene.
Water.
Yeah, and see, very basic things had this outsized effect on human longevity and health. And the tube example is a wonderful one. You can actually draw this on a map. Well, wonderful is probably the wrong word, but a very striking example. I suppose the lens I look at it through is a little unique in that I think that if we want to improve health further, we have to change the patient. And I'm not just talking about changing their behavior, I'm talking about changing their DNA. I mean, we build genetic medicines. And one of the things that's interesting about it is when I first got into the field doing gene-modified cell therapy, these are the most expensive, cumbersome things you can hatch up. They're only the purview of the wealthiest of places. But gene therapy itself doesn't need to be that way. And it actually led to a project we're trying to build, something called an open source in vivo electroporator, a tool to do gene therapy in the developing world. And you think about it like a cold cryogenic supply chain with monoclonal antibodies going to Africa is basically a non-starter. But DNA itself is pretty tough. Like, you can put it in a backpack. We pull it out of mummies occasionally. And so you could go there and inject a person once with this, and their body would produce a treatment indefinitely for years. And I think that like I said, it's a very different approach than a very different lens to look at it through. And I am admittedly a sciencey guy here, a technology guy. But that we're building tools that I think can overcome these divides to a certain extent. Because I mean, one of the big differences with advanced biologics that improve the quality of life quite a bit of people who have access to them. It's a lot better than the old school small molecule poisons. But they also are very limited in where they can go. And so the ability to turn the patient into, say, their own drug factory, or to actually remove damage that's inside of them, doesn't require them to go to the hospital every time now. It doesn't require anything other than a clean needle once, basically, or maybe for years. And so I think that this kind of level of advancement in medicine is really significant. I guess to put it in context, when I started Immusoft, I think it was 13 years ago, there were no approved gene or cell therapies in the US. It's before there were CAR T cells, it's before there was even Provenge. The only thing it really had is things like tissue transplants, just predate the FDA. But now there's more than 1,000 in clinical trials. Like, these things are rapidly going. Like, every tool we use in the lab today, it basically didn't exist a decade ago. I mean, there's a massive influx of new technology and innovation, and I think that to the extent we can remove the regulatory barriers to it, like, this is how you level the playing field. You have them come in for once and you give them a shot, and now they have the same advantage that someone else did.
I think one challenge there, though, still are the policy barriers. Because I think, I always think about, great example I heard from somebody who used to work at UNICEF, where, you can go into a place, you can build toilets, you can put the pipes in for clean water, et cetera. But if you don't have the enabling policy environment to keep the water flowing through the pipes, all of that innovation, all of that technology is meaningless. And I think we talk a lot about, R&D gaps, innovation gaps, technology gaps, et cetera, but we really face a fundamental, distribution and uptake gap. We have a lot of things out there, like digital health, that I think can really help us unlock things, but they're not getting to the places where they need to get to. Some of that is, and I used to work in vaccines, so, the cold chain is really important. How do you get around that when you don't have roads, or people live on small islands? So you can put things in these, there's a refrigerator called Arctex, which is made from NASA kind of technology or something, and it keeps things really cold in the desert, and you stick it on the back of a camel, and you go across the Sahara. And all of that is great, but there are sort of very limited fixes. The other option is take the vaccine out of the cold chain. And so what is the innovation there? Well, you look at thermostability of a product. And this is, I think, getting to, DNA.
Yeah, our COVID vaccines.
You can stick DNA in a backpack. I just think we often, innovation continues. It's like we've made these kind of well-worn paths, and we innovate, and then we follow the same path. And it's like we've innovated the product, but not the process and not the people. And so, healthcare workers are not trained, to think outside of the box in terms of how do you do delivery. I think about, rural areas where you've put a health facility in and it's open from 9 to 5, and female-headed, households where the woman has to work. She can't make that time. She doesn't bring her kid in to get vaccinated. We have a missed opportunity for vaccination. We don't get the growth monitoring check. We don't get, for these kids. And when you get that child into the health facility, you've now unlocked all of this access. And so I think for me, when I think about where the future is, I mean, like I said, I think there's an investment gap and things like that, but I think we really need to think about small, incremental innovation and not just transformational innovations. Everybody really just wants the shiny new thing. We want to drop our vaccines with drones or whatever, but take it out of the cold chain, teach community health workers how to vaccinate instead of needing, highly trained health professionals, et cetera. It's that kind of innovation, is really important. I'm totally for blockchain and everything like that too, but, I think we also need to think about some of the smaller fixes that I think can be really helpful.
I think for me, for mental health, I agree that we need both process and product innovation. But my answer to the mental health situation is novel, open, transparent models of public-private academic partnerships. So if the COVID pandemic taught us anything, to me, the lesson was, there was knowledge, there was research going on in academia for decades. Right, this technology existed, but it took, COVID for everyone to come together, and 10 months later, we had a vaccine. It's unheard of. If we look at, for example, and as I was watching it, I was thinking that suicide is now the leading cause of death in population, I think up to the age of 34 in the U.S. after unintended injury. If we took it as seriously as COVID, do we really not know how to approach it? Why don't we have that sense of urgency? I think we need academics, we need scientific input to discover new therapeutic targets, to do interesting out-of-the-box thinking and research. We need industry to deliver funding. We need industry to bring commercial expertise and regulatory expertise, how to take, the development to the market and scalability, and we need government to support these partnerships with policy. And the other point is that in mental health, as I said, I think 3 times by now, we don't have hard endpoints, and we don't really understand the interaction between genes and kind of neurophysiological processes and environment. So if you think about cardiovascular disease, it's the Framingham study that brought our understanding of environmental factors to the modern level. We understood the modifiable factors and we understood non-modifiable factors. We don't have the same thing in mental health. We don't have the same kind of prospective observational approach to mental health. And that really kind of separated, siloed efforts in kind of race for drug development does not address the complexity of the issues. So that's my, kind of few thoughts on that.
Thank you.
Yeah.
Thank you all for sharing those fantastic answers. It's clear there's a lot of challenges, but it's also clear there are a lot of great minds that are thinking of how to overcome these challenges. And for me, that's what I think the future of healthcare is going to be is fantastic people like this thinking outside of the box, seeing these problems, and figuring out very smart, clever ways to address them. So we have about 20 minutes, 19 minutes for some Q&A from the audience. So yep, okay. Do we just pick one, or whoever gets the microphone first? Yeah, sure.
Hi, thank you for an amazing discussion. That was really fascinating to listen to. I just realised I didn't introduce myself. My name's Janelle, and I'm doing a patient safety fellowship at Roche. Dame Anne, I think you mentioned earlier that the medical world is late and behind to this digital revolution. Yes, it's a highly regulated space, but besides that, do you think there are any particular reasons for that?
I think it's interesting that we actually innovate at quite a substantial rate. You think about, every time in the decades since I've been in medicine, we've seen a massive amount of change in treatments at a sort of individual level. I think this issue of remote practice is quite challenging to the profession because we're very used to that face-to-face interaction. That's the first thing. Secondly, the digital approaches and machine learning approaches, or even AI in medicine, involve, by definition, access to enormous amounts of patient data. And that's actually one of the things, if you're going to build technologies, for example, let's take an example, reading mammograms, which has now been done by machine learning technologies, requires a tremendous amount of access to data. That's another issue that's been an ethical and big debate about access to data. It involves quite substantial system changes, like data in the NHS. I think you'll be familiar what a difficult problem that's been. The electronic health record is still not solved as a problem in the UK. We're getting there, but there are all those things. So I think there are professional issues. There's issues of training, staff not feeling comfortable with digital approaches. We've been very slow at moving from writing notes into digital, just literally the skills of the workforce. So workforce training, access to data, capability, which I think has been changed quite dramatically by things by HDR UK, and the pandemic actually has driven a lot more data sharing, but some of that's been under a sort of emergency provision during the pandemic. And then I think the whole process of health systems tend to be rather like a juggernaut. They take a long time to turn around, and I don't think people have necessarily recognised the opportunities in the NHS. So I think there are all sorts of reasons, but there needs to be a systems approach, and we have to move pretty fast on this because so many other areas are now really moving forward on this. But we need to take that forward, and it does go absolutely right from the technologies of hospital at home and that kind of thing, to machine learning. And also, in the area you're dealing with, you need massive amounts of data to develop some of these understandings of the genetic variation in populations in order to be able to make the kind of interventions that you're talking about. And that, again, is hugely reliant on data. So some of it is the capability, technical capability, some of it is the system, and the whole lot's got to work together in order to make those changes.
Thank you.
Yeah, hi. I'm Chantal. I'm a master's student at Lund University. And my question is like a little bit more abstract, but it definitely applies to your field, because when you were asked what the main problems are, I think basically all of you went more into the science is actually quite okay, but the policy and the systems in which this science is embedded is like not working with us the way it should be working. And on that issue, I think my question is, how do you want to, or who's responsible for bridging this gap between science and the actual system in which this science is embedded? And so that would be my question regarding to that. Do you think it's like more like the two groups should be more integrated from their thinking, or it's like a completely different field or new kind of job perspective to bridge those two things?
I can take a stab at that. I think, and then this is very much going to bring in my personal bias, because I work at a public-private partnership now, and I worked at a public-private partnership before this job. So clearly, I think this is a very, important model and useful model to have. But I think, we have siloed innovation in the private sector, and we have siloed big, meaty problems that are very difficult to solve in the public sector. But I think that has changed a lot over the last, say, 20 years. It's about 2000 when like all these big public-private partnerships came up, like Gavi and the Global Fund and others. And I think it really changed the way that we thought about how the public sector and the private sector come together. And I think one, in terms of kind of who is responsible or accountable, I would say everybody. And I think what really works well in a partnership is people in the public sector being comfortable with working with people in the private sector, but also everybody recognizing strengths and weaknesses. So there are constraints. You work with people who have, can have very different kind of objectives. But if everybody has a kind of common overarching goal, I think you can find together a pathway to kind of towards achieving that goal and leveraging each other's strengths. So I think for me, and what we are seeing a lot of now is in the private sector, that's where people take on risk. And that's where risk should sit. I don't think it's for the public sector and public money, for example, to invest in really risky things with kind of high risk of failure. That's what the private sector does really well, because they are willing to do that if there's a reward. And then it's on the public sector to put the reward out there and say, we will make the environment attractive for people to take this risk on. And that has to happen together. And I think when we see that, this is the push and pull, of not just the market, but of development. And I think when we see that pull being put in place, you see a lot more people coming into kind of the private sector. So I think there's a kind of a balance there. And then maybe the last thing I'll say in the private sector is that the private sector also has to be willing to compromise. I think this is, an area where, we're fraught with, and I'm not going to get overly political here, but we're fraught with a lot of challenges in terms of, we want some very laissez-faire, hands-off kind of policy, and it doesn't work in public health. I think there has to be a lot more partnership.
But the vaccines are a good example. The COVID vaccines are a good example of where that worked, I think. Yeah.
Mm-hmm. Well, it's worth noting that, Moderna, notably, had been living off government grants for a very long time, building Department of Defense vaccines for all sorts of stuff that no one took. So I'm curious what you think about this. Like with the AMR point of view or a problem, it seems like you could have the United States government say, okay, we will, if you build a drug like this that is approvable, we'll just give you $6 billion for it over the course of like a decade. And you think like, if you're losing 6 million people a year to that disease, that's dirt cheap. Like it's nothing. That's $1,000 a patient. It costs less for me to get like a normal antibiotic at the hospital. Vancomycin will get you more than $1,000. And so that actually seems like in the category of stupid, simple problems to solve. Like it is not even remotely challenging with the resources available. Like and to your point, it's biotechs that make these. For those who aren't familiar with the number, 3/4 of all the blockbuster drugs on the market are made by tiny biotechs. So big pharma is a whole lot more like a record label than a band. They sell drugs, they don't make drugs. They're demonstrably bad at it. But I mean, sorry, the big pharma. No, I mean, this is actually, I'd say, a very positive relationship with. You have these small, innovative groups that, like, we build something cool and we have no ability how to distribute it to the world. So, big pharma picks it off. But yeah, in this case, like, there's a lot of biotechs who would jump at something like that. You say, okay, well, if I get this over this hump that you define, then I get $1 billion a year for 6 years or something. And I don't know why. It
doesn't even have to be $1 billion a year, to be honest. I mean, a novel antimicrobial for the market to be attractive, I think we're looking at something like $3 billion over 10 years, globally.
Yeah.
So I mean, that's 3 to 4 billion.
It would take more to attract me.
I mean, maybe the well,
but
an antibiotic is not intended to be a profit-making, product. I mean, you're kind of going into it out of the goodness of your heart, in a sense, and you've got 10 years lifespan on it, and then it's not going to be that effective anymore.
Yeah, well, from goodness of the heart doesn't seem to be panning out so well for us. You're like up to here, right? That's the problem. And so,
but I mean, you're right. I mean, this is the challenge, and I think the number that I heard, recently was something like the cost of a cup of coffee a day or something like that for everybody. So within your population, I mean, that's cheap, and you think about what we put towards other. What we put towards COVID, for example. And I'm not suggesting we're going to replicate that in every area because that's completely unrealistic. But yeah, we can invest that in health. I mean, health budgets across the world are just, well below what they should be to ensure good health and well-being for country populations. I think that's the first problem to begin with. So I think if we could up those budgets, perhaps decrease some budgets in other areas, I think we would see a lot more of this kind of thing happen.
Thank you very much. I'm Miro Gasparag. I'm a CEO and co-founder of Sensible Biotechnologies, which is a YC startup. I see another fellow founder there, developing a new way of mRNA manufacturing, faster, better, and with improved properties, so we can democratize this marvelous molecule. And while I'm talking about that, I'm also working on biosecurity for the Slovak government, and I see some kind of drastic positive things in preventing pandemics, like Operation Warp Speed just came in and allowed us, through the global coordinated effort, just some kind of mild amount of vaccine, 4.5 billion doses in 2021 is great, but by far not enough. But we've been able to get a vaccine throughout from the starting line to the finish quite quickly by the coordinated effort. And that's the good of the kind of health policy. And then there is the bad of the health policy. That is that there are countries, and I'm not pulling out any kind of national secrets here, but where if you talk to the chief army doctor, he will tell you our pandemic preparedness or biological security is zero. I mean, what do you mean by zero? Yes, there's nothing. There's no labs, no plan, nothing. I'm not naming the countries, but... And my question is, that kind of is a bimodal resource allocation problem. We need to allocate this outsized amount of resources, and it's indeed salutary for addressing these immediate big problems like a pandemic. But whatever we do there, it's going to be quite problematic if we will have a bunch of countries, probably like most of them, that do pretty much nothing about the biosecurity. And I was really wondering about how the public and private sector can work together to let's say, redistribute the knowledge and encourage the flow of the resources so that we can build systems that are not just, let's say, very well controllable, but also very robust in terms of not having a single country is doing very well on the biosecurity front, but some of them just having absolutely nothing. And my subsequent question would be how entrepreneurs can help that. So yeah, thank you very much.
I think the the creation of a viable nucleic acid printer and microfluidics technology will go a long way for that. You laugh at this, but I mean, this is a conversation with NASA years ago about putting these things on, a space station. You can send a treatment wirelessly to Mars. But I mean, they are two tools that, barely exist to some extent today, but are both actually being used in products that are going into people. And the ability to develop and iterate very quickly on the payload side and to produce at scale on the delivery side, I think are these ways that would substantially level the playing field, because you don't need to have specialized manufacturing for each of them anymore. I mean, printer's a lousy example for sure in terms of, or poor wording, but these things that can assemble long nucleic acids on the fly. And I mean, we can already make, liters and liters of, like nanoparticles in hours. Like you could easily scale these things up to the point that you could treat a planet, and you could do it in a distributed fashion where people can iterate on them on the fly.
Anyone else?
Yeah, let's not talk about the policy ramifications of that.
No, I mean, but just to go back to the systems point, that these things are all, I mean, I absolutely agree. We need much better detection capability. This is what you're talking about. I mean, you need a very strong detection capability, but to notice you've got anything wrong in your healthcare system needs a healthcare system that says, whoa, there's something funny going on around here. So, you do need you need the voices, you need the lot, you need the voices on the ground who have enough, going to detect early, and then you can use these sort of technologies. Been fantastic. I mean, just to give a small example, which is not about detecting a pandemic, but about using these technologies. And we've been working with HIV diagnostics and getting people to be able to do their own tests, because it's such a stigmatized disease, so that helps the community because people do their own tests. They take a photograph of the test with their phone, because that's the one thing everybody does have in terms of, people have those, so you can do your own diagnostics, and you can link those up to health systems. So these kind of technologies, and that's a very simple technology, but absolutely the ability to sequence, on the ground, to be able to develop some of, to have PCR capability that you can use on the ground and doesn't need a lab. All these outside of a lab detection systems are hugely important to detecting future pandemics, but you need alongside a capability and a responsibility to do that. Now, every country in the world has a self-interest in that. I mean, to detecting an Ebola epidemic or detecting COVID. And so that international global collaboration, which has always been done through WHO, which is significantly underfunded, as you know, but we do need much strengthened global systems to which everybody contributes. And, there is a lot of technical capability and technology that could contribute to strengthening those systems, where you don't need the kind of high-end labs and so on, and the cold chains and all the rest of it. So resilient technologies in these situations are really important more generally.
Maybe I can just add one thing, which is, we could probably get by without every single country fully investing in biosecurity. I think the safety net will be there. There will be holes, but it's strong enough. What I think the challenge is those countries risk being left behind when something happens, and they're having to free ride onto what other countries are doing. That to me is kind of the bigger problem. It becomes a problem of political will. And if a government is not willing to invest in that, there's nobody else, there's not some other body out there that can say, you government, you need to do this. It's the will of the people that gets governments to do things. And so collective problems require collective solutions. And I think this is where it's really important, things like, people voting and putting the right politicians in place. And I don't know, these are kind of boring things to talk about, but that's the policy enabling environment that we need. And I think particularly in health. I'm going to bang the drum again, but we need to invest. We need to invest in health and well-being, in prevention, in public health, et cetera. And we don't invest in that.
The boring
it's not sexy.
Important category is massively overweighted in this field.
Yep.
Well, we unfortunately are out of time for additional questions. I am so sorry. But thank you to all of the panelists for your incredible insight and answers to all of those questions. there were a lot of other hands raised. We're about to go to lunch, so if there are any questions that you would like to follow up with any of the panelists with.
No, I said just find Dame Anne.
Yeah, you can bug her. There's gonna be a line. Yeah, you might not get to eat. Yeah, no. But thank you for listening. We really appreciate it, and yeah, have a good lunch.